All right, friends, we're going to go ahead and get started. So if you want to make your way to your seats, and we'll keep the talking through it over here. You're wearing my favorite coat. I have my favorite coat. So you love it. Just
If Audrey has it, I know.
oh, yeah, yeah. You doing it?
Good morning, everybody. We're going to get started. So this morning we have with us Dr. Jonathan Torres, who is a board-certified family medicine and osteopathic physician. He's affiliated with my old alma mater, Atlantic Health System. Dr. Torres helped found the Family Medicine Residency Program at Morristown Medical Center. He is a fellow of both the American College of Family Physicians and the American Academy of Osteopathy. He brings deep expertise in family medicine, preventive care, and osteopathic manipulative medicine. This is a real privilege to have him here. The family medicine physicians are, he actually trains family physician residents also. So whenever you get somebody who's an instructor of doctors, you know you got somebody smart. They need us honest. So thank you, Dr. Torres. Take it away.
Thank you very much. Thank you, everyone. Good morning. So today I was going to speak about cancer screening and prevention, and I asked Audrey, how do we want to do it? Do we want to have a presentation, like on a big screen, or just a conversation? And we couldn't really decide, so God did. So I do have a presentation, if you'd like I can mail it to you, but we're going to cover several topics, and I had named this growing out of control, because essentially that's what cancer is. Cancer is a normal, healthy cell that we all have in our body, and at some point in time, it just decides to do its own thing, to throw caution to the wind, not listen anymore, just grow unchecked. And because it's not following any of those instructions anymore, it can create trouble, because it grows beyond the confines of what it normally should. And the problem usually isn't the cell itself, but it's where it is. And as it grows, it impacts the anatomy and the problems and the organs nearby. And so what we see many times is dysfunction of those organs. So when we're talking about screening, what we're trying to do is identify somebody who could be at risk and identify, can we find this before it grows to a point of starting to impact that organ? Because if we wait until we see those symptoms, many times it's advanced cancer. It's either grown so large that it's affecting that organ, or it has spread to another organ where its impact is more profound. There's that old adage of an ounce of prevention is worth more than a pound of cure. And so going through, we're going to cover several different cancers. Starting from colon, lung, breast, prostate, testicular, kind of what is it that we can do to screen, and then we're actually going to talk about a couple of emerging things that are out there to try and help identify all of the other cancers that exist. Because you can have a cancer of pretty much any cell. Skin cells, colon, lung, pancreas, ovary, pinky toe, pretty much anything can wind up leading to cancer. So with colon cancer, this is actually the number 3 cause of death, accounting for about 50,000 deaths per year. But it can be really easily caught if we screen in time. So the natural progression, like I said, it starts small, one cell, and it grows and grows and grows. With colon cancer, we have an opportunity to catch it when it's still very small. And the way that we usually do that is by using a colonoscopy. That's been the historical way that we're able to do that. But even there, we've had a couple of innovations. Things that put us at risk: smoking is pretty much a risk for any and all cancers. But obesity has been shown to be linked to this. somehow correlate with how much we're using our body does have an impact on how aggressively our body surveils for these cells that are going through these changes. And on a regular basis, most of us today will have a cancer cell, but our immune system will identify it and destroy it effectively. It's the ones that slip through the crack, and being inactive seems to make that a little more prominent, that it can elude our immune system. So what can we do? Well, quit smoking. Trying to get some more exercise, trying to increase vegetable in our diet, and screening. So screening used to be colonoscopies. And colonoscopies, I don't know if anyone here got to enjoy the old school ones where you were awake. But those had a very low rate of people actually doing it. So nowadays, you get sedated entirely. And we recommend that we have that done about every 10 years, assuming everything's completely normal, because those cells grow so very slowly. And with colonoscopy, we're able to see inside the colon itself to those inner wall, and that's where virtually every cancer cell winds up starting, because that's where we have the most cell turnover, reproduction. And so doing that every 10 years, and we used to start at 50, now it's 45, so we moved that up some. Or people with family history, we usually say 10 years before that family member was diagnosed. So if they got it at 45, you're starting at 35. If they got it at 35, 25. And there are some conditions that can make that more prominent, like inflammatory bowel disease, such as Crohn's, ulcerative colitis, and a couple of genetic conditions. But we do now have Cologuard, which is much more convenient. So with colonoscopy, we have to take the prep, which is usually the worst part, find a driver, take the whole day off, and they sedate you, you do the procedure, you wake up, you go home, and that whole day's kind of a wash. With Cologuard, it's just a stool sample. So you collect the stool sample at home, in the convenience of your own home, and you mail it out via UPS. And what that does is they'll look in that for DNA markers for malignancy. And they can actually identify really effectively if there's any change. Not as effectively as a colonoscopy, but Cologuard you can have done, and it's covered fully by insurance, but we do it every 3 years. So it's more often, but less invasive. And that's what we're trying to see as we go forward, thinking about cancer screening, is are there ways for us to be more effective, less invasive, and catch more cancers earlier on? Questions on colon cancer? Yes?
When my mom hit 80-something, I was concerned, because I was thinking about old pipes and how you could pop a hole in a pipe without intending to, checking for a problem. And I wondered, when do we stop doing those tests?
So for the most part, it really has to do with the condition of the person. You know, once we get over 65, I often tell my resident the number of their age really doesn't matter as much as their underlying condition. Because we will see 90-year-olds who look like 66 and 66-year-olds who look 90. It has to do a lot with the lifestyle they've led and genetic factors, but once we hit a point, what we start looking at is what is the likelihood that this is going to really benefit that person. And so the most common metric we look at is how much longer do we reasonably think that they could live. So if they hit 80 for colon, breast, pretty much any of that, if I have patients who come in and say, my grandma lived to be 98, you're probably going to need this because we have better health care now. You're probably going to live even longer. So doing it at 80, at 90 probably even makes sense for that patient, because the likelihood that they're going to live long enough to benefit is important. The other question is, would they do anything about it? With screening, our goal is to catch it very early when we can treat it very easily with a lot of sarcasm, right? So if we catch stage 1 when it's really pretty early on, our interventions might just be taking it out, or taking it out in some radiation. It could be chemo, which is usually the big decision people struggle with because of all the side effects. And so if I have a patient who says, no matter what, I wouldn't want anything, the next question I ask is, would you want to know to plan the rest of your life? Because that could be an issue as well. You find out, hey, I do have something, I'm not going to do anything about it, but maybe I do need results and you test it. I don't want to know. I don't want the results. I'm not ready to know the results. I don't want to know. I'd rather just not know. Which sounds crazy, probably to a lot of people, but for her, the anxiety about what if was more than the reality. The irony was it was negative. But you can't tell someone without their permission. And so it all really comes into that. The next one is lung cancer. So lung cancer has changed a lot as well when we're thinking about what it is that we're doing. And so this is the third most common cancer. And this actually by itself is responsible for more deaths than any other cancer. So lung cancer is 1 in 5 cancer deaths, 20% of all of them. And risk factors, unsurprisingly, smoking. Smoking is a really big one. Also, occupational exposure. And so what do I mean by occupational exposure? Well, we always, in medical school, we're taught you think of asbestos. So asbestos is a big one that causes the subtype of lung cancer. But miners, you can have anthracosis, which was coal miners, or black lung. You can have silicosis, which is from sand and glass workers. Here in Jersey, the hotbed of pharma, we can see this in labs. We didn't have good vent hooding, so that you were actually inhaling some of those noxious chemicals that we're using, some of the solvents and things that can irritate the lung and wind up bleeding there. And like I said earlier, cancer cells are cells that are reproducing and they just go off the tracks and reproduce wildly. So we see this a lot of times where we have a lot of cells turning over. So in the GI tract, because we're digesting food, we're digesting cells too, so our body replaces our GI cells very frequently. Same with the lung, is our lung cells and the alveoli wind up going through a lot of rejuvenation and change. So those tend to be the ones that we see. And the lung is also a little unique, and this is where I struggle a lot of times, because many cells that are cancerous, like I said, they grow, and then sometimes they travel. Well, if you have cells from really anywhere but the lung, they will tend to travel to the lung. And that might be where we see it. So someone has imaging and we find a mass, and the default that people will say is, well, they had lung cancer. And my next question is, did it start there, or did it go there? Because many times it will wind up traveling there. The liver is another place commonly that they'll travel to. When we thought about cancer screening for lung cancer, what we used to say is, all right, smoking is a risk factor. So if you smoke, we're going to get an x-ray of the chest, 2 views, one in the front and one from the side, every year. The problem is that that's not super accurate. You can see very large masses, but it doesn't give you a lot of discrepancy between, is this just I'm looking at a blood vessel head on, or it's a lymph node. It's kind of, you don't really know necessarily where things are. And so what we've done is we've transitioned to not quite a CAT scan, which is a good amount of radiation, but now there's a low dose CAT scan. So it's less radiation, it's focused on the lung, and we do this not for every person who ever smoked a cigarette. We do this for people who meet a couple criteria. So between the ages of 55 and 80, right now, just because it's a newer technology, people who have smoked 20 pack years. Now what does that mean? So you take how many cigarettes you smoke a day, and you multiply that by how many years you smoked that much. So if you did if you smoked half a pack a day for 40 years, that's 20 pack years. If you did a pack a day for 20 years, that's 20 pack years. If you did 3 packs a day for 37, that's a lot. At that point, you're into the triple digits. I've had those, and then of course Marlboro Red, because you're gonna go big. But the benefit of a CAT scan, for those that aren't familiar, is it's still an X-ray, but it goes through a computer, and what it does is it gives you slices. And so those slices for a low-dose CT are about 3 millimeters apart. So if something is 3 millimeters in size, we'll pick it up, which is much smaller than what we would see with an X-ray, where if you're doing a chest X-ray, you can see something a centimeter, maybe, usually 2 or 3. And that doesn't sound like a lot, but if you think of that's a radius, or a diameter rather, right? So it's growing in every direction. So it does give us a lot more sensitivity to say, is there something there? So we start doing that every year, starting, like I said, at 55. And then if we find abnormalities, we track it and keep an eye on things. It doesn't mean, oh, we found something, oh my God. It means that we have to look more closely, so maybe 6 months, maybe 3 months. There's a lot of tools that we have, but the CT tends to be really helpful. The other thing that I do tend to look at and sometimes can be helpful is any other imaging that is in the area. So I found things on shoulder x-ray, someone fell and hurt their shoulder, we incidentally found lung cancer. Somebody has spinal issues, same thing. So sometimes we'll pick it up just randomly, but these are those recommendations of, if we have those risk factors, then that's what we want to consider doing. Questions on lung? Yes?
What about smokeless tobacco?
Smokeless tobacco, not for lung cancer. So with lung cancer, it's really the fact that we're inhaling it. Same is actually true with smoking marijuana. So they did a study over in the Netherlands looking at smoking marijuana because it was, oh, it's safer. And what they found was that it actually has a much higher rate per usage than cigarettes, largely because of how it's used. So if you take an inhalation and you hold it for a very long time, which allowed any of those particles that you inhaled to settle into the lung. And so they could wind up creating more and more trouble. With smokeless tobacco, whether it's chewed, it is not quite as much, but we do see that where that goes. So that has a very high risk of gastrointestinal cancer. So colon, tongue, throat, stomach, intestinal, pancreatic, because if we're chewing on it, we're swallowing intermittently, and so we're having much more travel there, where it can wind up wreaking a little bit of havoc there. The same is true though with smoking, because you're putting smoke into your mouth, and you're going to swallow that as well. So you do, even with smoking, have increased risk of those gastrointestinal.
I guess I'm referring to the trend of putting a little packet of tobacco inside your cheek and gum.
Yep.
Which
Yeah.
is growing in usage, I guess.
Yeah, I mean, it's happening, you know, it all depends. You know, vaping is another one that's very common among a lot of people. There was a lot of concern, there was some illegal, like, marijuana packing that caused the popcorn lung for a while. The e-cigarettes and vaping is also not great, but we haven't broken out what is the explicit risk of one versus the other. But it is something we are assessing for with our patients that are doing any form of nicotine. Same with marijuana, because there's so many forms that people are using. Yes?
Are we as Jerseyans more vulnerable to lung cancer than, let's say, people in Vermont, the Dakotas, or Wyoming, given the sheer number of vehicles on the road here, spewing all sorts of stuff out, plus, you know, the industrial sorts of stuff that goes on?
We haven't seen as much with the lung cancer that there's a geographic location. We definitely do see with pulmonary disease. We see asthma. We see a lot of rates of asthma, in particular in areas that are more industrial. So urban areas, suburban areas, near factories, where those can play, you know, a role. But that's more of an inflammatory condition than a kind of turnover condition. So we haven't seen that. We are fortunate, though, you know, if we looked nationally, we are much more capable of identifying and treating things earlier. And so our burden of deaths tends to be usually better because we
And
find
I guess, you know, a lot of good hospitals here, whereas in a lot of other parts of the country, it's a big issue.
Yeah.
Not much.
Well, in some places, just hospitals.
Yeah.
You know, I mean, there are places where you know the nearest hospital is over 100 miles away, and so communities don't have easy access to get some of these things done, to see a physician. So that does really delay things, and then the later we find things, the more serious that burden is. Yes.
I thought it was interesting when you said that just because you found that something originated there.
Yeah.
So can you tell where it originated from, or do you just like do a whole different?
Yes and no.
Okay.
So, you know, it depends. So usually if we do find something, just to go through kind of that whole process, right? We found a thing, we think it could be cancer. Usually what we're going to do is we're going to do a CAT scan of the head, the chest, the abdomen, the pelvis, and we're going to look for, can we identify a primary mass? We're also looking for, has this gone anywhere else? Right? Because if we have, okay, I found this in the lung, and it's also in the brain, and it's also in the, the lymph node, then that would lead us in some directions. We can go when we take a biopsy. So that's part of it too, is if it's in the brain, that might be dangerous. If it's in, a lymph node, that'd be a lot safer to get a sample.
But like if you took a biopsy of something in your lung, are there like liver cells in
Yes.
there?
Yeah, so you can to an extent, right? Because like I said, they start to grow out of control. And as they start to grow out of control, a lot of the other checks, it's kind of like, if you're going down a mountain and you lose the brakes, you just pick up speed as you go further and further. So it starts, okay, I'm not listening to the signals telling me to stop, and because I'm speeding up, I'm not doing everything correct, and so you see a lot of mutations that take place in that cancer. So a lot of times we'll be able to tell this is Mullerian, for instance, and Mullerian basically means female reproductive tract. So probably ovarian, but could be endometrial, uterine, some of those categories, but we have a general sense, or this is adeno, probably colon, like you can get a lot of times good clues that can narrow it down based on individual chemical markers that they'll look at. And that's why if you get a biopsy, a lot of times, we'll get early results in like 2 days, but full results take like 7. Because the early is like, all right, there is cancer.
Right.
But now they're going and mixing all different things to figure out what type and can we pinpoint where exactly it came from. And even from a treatment perspective, genetics, we've gotten to a point where we can look at it and say, oh, well, based on this genetic and these, like breast cancer, which we're going to talk about soon, we look for, is there an estrogen receptor, is there a progesterone receptor, and is there a Herceptin receptor? And so you'll hear a lot of times like ER positive, ER negative, PR positive, PR negative, HR positive, HR negative, triple positive. And that's for breast cancer, looking at those receptors, because some of the treatments will work on those receptors. And it also means that we're probably not going to do things. So if you have an ER positive or a response to estrogen, we're probably not going to give that woman hormone replacement therapy because it's just throwing fuel on the fire. We usually, for that, there will be tamoxifen, which blocks estrogen to try and reduce that reproduction and expansion of the tumor. But for others, it can help give us guidance of what pathway of treatment would be most effective, because they can look at these, especially AI is one of the most promising in medicine, is that you can have AI look at those genetic samples coupled with what treatments they got and patient factors and crunch hundreds of thousands of patients and say, hey, the people who had this little subtype did best with this treatment. So that's where we'll start. You still have an oncologist who's going to explain all of the risks and counsel and do all of those things, but it's an opportunity for us to use that information to guide care. Yeah. So breast cancer. So this is the second most common cancer in women, pretty much right behind skin cancer. And it's the second leading cause of deaths in women. For women that are Black but not Hispanic, and or Hispanic women, it's actually the number 1 cause of cancer death. So what are our risk factors? Smoking. Genetics. So a lot of people think of BRCA or BRCA1 and BRCA2 with breast cancer. And it does increase your risk a lot, and it changes how we surveil those women. But BRCA only accounts for about 10% of breast cancers. So the other 90% of breast cancers happen what we say spontaneously. So it's not related to those. Can be related to other genetic conditions. So a lot of times we'll look at the family history and it's like, oh, well, their aunt had breast cancer, and their grandma had breast cancer, and her sister had breast cancer. And you can clearly see there's a pattern, but they're not BRCA1 or BRCA2 positive. Same thing with men. Men can get breast cancer, especially if we're in that condition. And if a man gets breast cancer, then a lot of times we're looking at genetics too, because it's so atypical that it does drive us kind of down that road. How do we screen? Well, this is different, and we were talking earlier about guidelines and recommendations. So there's actually 3 different guidelines, or 3 different organization guidelines for screening for breast cancer. So there's the USPSTF, which is the government, the U.S. Preventive Services Task Force, and they have the least rigorous testing. And then you have the American Cancer Society, which has the most rigorous testing recommendations. And your physician is going to usually counsel you which of those they recommend. Now, what led to this? Well, one, we want to find breast cancer. Two, we don't want to hurt women in the pursuit of trying to find breast cancer. And so we used to do this every single year. We used to start early. We used to do self-breast exams. We used to do all these early biopsies and samples. And we found that we weren't really helping women most of the time. We were a little too aggressive in searching it out. And so we had women having multiple breast biopsies that were normal, the anxiety, the stress. And so the guidelines shifted and said, let's do it a lot less. So USPSTF had said nothing till 50. And a lot of women were like, my aunt was diagnosed before 50. My friend, my cousin, this woman I met got diagnosed at 42. This woman was diagnosed when she was pregnant. Like, how can we wait all the way till 50? So they have revised because of the backlash. Everyone pretty much went with the American College of Obstetricians and Gynecologists or the American Cancer Society regs. So the USPSTF kind of drifted back a little. So they say starting at 40 every other year, the USPSTF. With that expectation that cancer grows slowly, and so every other year should be enough, and we'll balance the harm of unnecessary testing with identifying things. American Cancer Society is a little different. So for them, they say that at 40 you can start having an annual mammogram if you want, right? Discussion with your physician. But you can also just do every other year. And then from 45 to 54, they're saying you should get a mammogram every single year. At 55 on, they then say you can choose every other year if you want. So they give a lot of discretion to the physician and the patient to decide what kind of, how aggressive they want to be in looking at things. Now, the College of Obstetricians and Gynecologists is the most aggressive. They say starting at 40 every year in perpetuity. As long as we expect there to be reasonable, length of life after this. The screening themselves is usually a mammogram. The younger women are when we start doing mammogram, the denser the breasts are, and so it's common that we will do an ultrasound as well. Because sometimes we'll see something that we're not quite sure, and it's very common women will have something called fibrocystic breast disease, which basically means a fluid-filled sac in the breast, which is a common finding. When women are, reproductive age, through that whole hormonal cycle that we see menstruation happen, we have changes in the breast happen as well, preparing for, do I need to get ready to lactate, to go forward with a pregnancy? And so we will commonly do ultrasounds as well. We don't start there, but usually if it's necessary, then we'll do that. The other thing that can be done is breast MRI, right? So we talked about with the lung cancer that we went to CAT scan, but we're still doing mammograms that are kind of just one view, two views. It's not widely necessary for most women, except women that are at those higher risks. So if we know there's really strong genetic history, if there's a history of concerning findings previously, if they're BRCA positive, then we would usually do a mammogram and MRI, usually around 55 plus. Usually earlier actually, so down into the 30s even, that we're starting to look for things. And some women who do have those positives will say, look, I'm just going to prophylactically have a mastectomy and reconstruction because I want to take that risk. Questions on breast cancer? It's a lot. It can get kind of dizzying with all the things and the recommendations. The fact that there's 3 different groups can make it confusing because one woman may have a different screening protocol than another. Yes?
You mentioned that men can suffer from breast cancer. What tissue is involved?
Still breast tissue. Still breast tissue. So, you know, to that end, why do men have nipples? Right? Is we do have some, and if men are overweight, we can still have that fat growth. Now, we do not have, and we do as men still secrete some estrogen. It's just not nearly as much as the ovaries secrete. And so, but if we are overweight, then some of the fat cells will actually convert testosterone to estrogen and wind up having some breast growth. If you have that genetic predisposition, it also increases that risk. Yeah.
John, what's happening in terms of incidence? I mean, are the number of breast cancer diagnoses, over the last 10, 20, 30 years at a previous level, or going up?
They've been relatively level in terms of year over year. Yeah. It hasn't been much change. I think the goal is really just trying to identify as early as possible so that we're not missing anything. The other thing that did change was the self-breast exam that I mentioned earlier, and we used to say, oh, we should do that. The problem is, if that isn't done in a very structured way, it led a lot of women to feel like, oh my God, I felt something different. But like I said earlier, breasts change throughout the cycle. So that different could just be a hormonal change. And so, because it was not consistent how women were doing that, it led to a lot more concern of I felt the lump, which is relatively common.
And survivability?
Survivability has improved because of treatment, which, one, we have women that can identify earlier and say, I'm going to take more preventive action. There's been much more of a visual of a community awareness with a lot of the campaigns, and so pushing very much women's health from cardiovascular and breast cancer perspectives. Yeah, so those have both had an impact, but still much to do. Yes?
What's the general feeling today about hormone replacement?
So today, it's good. Yeah, so over my training I had, it's fine, to it's the worst thing ever, to maybe it's okay some of the time. And like many things in research, is if you look at populations, sometimes it can lead you down the wrong road in terms of your evaluation. We do know, like I said earlier, estrogen is implicated with some breast cancers. So if we were just broadly giving women that and they had ER positive, it would wind up causing more breast cancer and more advanced breast cancer, which was one of the concerns we had. They did also look and say it looks like there's cardiovascular risk that's associated with it. So that from the newest, most recent literature suggests that's not really as severe of a problem as we had anticipated that it was. There used to be a lot of expectation that, when we are reproductive age, our body is keyed up to stay healthy. And when we lose that, women start to lose bone density. And we see those risks of heart disease catch up to men. So that estrogen was kind of heart protective to a point. And then we saw that we were doing this and we had a lot more women having issues, and they interpreted that as it was because of the hormone replacement. Right now, it's more broadly accepted. I think we are still looking at what those underlying risk factors are. If women have a lot of heart disease, if they have a history of breast cancer or a strong family history, we might be a little more reluctant. And generally, we're trying to start it close to perimenopause, not just randomly. So menopause at 50, at 65, say, let's throw you on hormones. We try and keep it more together so that as we're starting to wane, we're going through perimenopause, that we're starting hormone replacement to maintain all of those things. Yeah. Yes?
Have you seen any correlation between IVF and manipulative cancer?
Not that I'm aware of. We're seeing women struggle with fertility, partly women having children later in life, and partly, I like to say, stress. In my office as a family doc, we take care of people of all ages, so we see kids through, older age and pregnancy and everything. And I very commonly talk about, the Industrial Revolution was only a few generations ago. And before that, our bodies were primed to do a lot of physical labor. Every day, all day. You wanted to wash your clothes, you had to walk down to the river, carry back pails, beat them on the rock, hang them on the line, mill grain into flour. living in caves, if you're in stress, it is not time to reproduce, because having a baby is a huge draw on your food, right? Your resources. And so with society being so stressed all the time, right? If you're a cave woman, you got chased by a bear, your fight or flight nervous system would fire, your adrenaline would spit out. But within a few minutes, one of two things happen. And regardless, you don't need that anymore. But the mortgage never stops chasing you. Your car payments never stop chasing you. Your student loans, stress, and family, friends, relationships. I mean, there's stress constantly surrounding us, and so I think in many ways that also winds up getting in the way. But it hasn't really associated with the cancer risk that we've seen. And a lot of the hormones that we're doing with IVF are short-lived hormones, and so they're not something that's very sustained. Estrogen, the other thing with estrogen, just before we move on, is there was a lot of people that were touting bioidentical estrogen as being safer than regular estrogen for the hormone replacement. And that really hasn't borne out. There's not a lot of research, so they say there's no evidence, but it's like saying if you never looked, how are you going to find the evidence? But women who have their own natural hormones in excess, so polycystic ovarian usually have higher estrogen. They have higher risks of some cancers, and so that was, largely uterine is the big one, but we do see that there's risk with even your own estrogen in excess. So it's a balancing act, but much more acceptable now. We'll flip over to men for a little bit. So prostate cancer. This is one that is very common. So risk factors for this, again, smoking, but age over 70, African American ancestry, family history, and obesity again. Now, I often joke with my patients that if God gave me a good news, bad news scenario, he said the bad news is you have to have cancer, the good news is I'll let you pick. It's prostate all day, every day, because prostate cancer is almost never fatal. You can have some rare aggressive forms of prostate cancer, and President Biden had one, but for the most part, men will live with prostate cancer for decades and die from something completely unrelated to it. It is cancer. We do still want to surveil it. Treatment has changed dramatically, but surveillance and identifying it is the big one. The things that we do to look for it have changed a lot as well. So there used to be the digital rectal exam, where you have a gloved finger and you feel the prostate. Now, the prostate is on the front surface of the colon when we're doing that exam, so we can feel maybe a third of it, which means 2/3 we can't really reach. So that by itself is not helpful. PSA is a blood test, and for a while we were using that, but that can be elevated for a lot of reasons. Riding a horse or a motorcycle, having a urine infection, ejaculation, they all can wind up in having a UTI. They all can make your PSA elevate. And so we used to freak out, so now it's usually, all right, don't do those activities. Here's antibiotics, let's recheck. But if we're looking at the trend, that tends to be where it's much more helpful. So we're checking every year, and we see, under 4 is kind of normal. Oh, you're 0.2, 0.8, 0.8, 0.7, 3.8. But what happened? Like, it's not abnormal yet, but that jump is weird. So we might investigate for that. The other thing is going to be symptoms. So the prostate grows around the bottom of the bladder. So urinary symptoms are the most common thing that men will experience. So if it's growing inwards, again, I may not feel it on the outside surface, but we may start to experience urinary issues. So urinating a lot at night. 1 or 2 times can be normal, more than that's not. Dribbling, change in stream, retention, leakage, those are all things that can be signs. And then really it's going to be starting at around 55, we're going to start looking at prostate screening, 45 if you're of African American ancestry, just because it's the safest of all the ones we discussed, but it's very common because of that, because you'll see men living decades with it, so, you know, the population is at any given time. Testicular cancer is the other side of that coin, so that is less common. That's about 1% of male cancers. So it's much, much lower, but it does affect people younger. So when we're talking about men from 20 to 44, it's about 50% of cancers. So it is pretty high, can lead to infertility. Infertility can also predispose it. An undescended testicle. So our testicles start as ovaries, fun fact. And then they descend all the way down. And sometimes on that descent into the testicle, into the scrotum, they don't quite make it all the way, and they get part of the way there. And as children, sometimes we'll try and either do surgery or some testosterone to get that to drop the rest of the way. But if they have that history, it does increase that risk of testicular cancer. And I am proud to say, not cell phones. It's been studied extensively. Oh, does my cell phone in my pocket increase my risk? But they have not found that. And for that is, screening is usually education. So we're talking to men 20 to 44 about, are you doing a self-exam? Same thing, what is normal? You know, usually testicular cancer is not painful. So it's not something that hurts. Breast cancer, same thing, usually doesn't hurt. But it's just an abnormality. The testicles themselves are pretty smooth, but there is, where the best deference comes out, there are some areas that can feel a little different, and that is normal. So figuring out what your normal is and making sure it's not changing. So those are the ones that we can screen for. But I said before, we have lots of cancers from lots of places. So what do we do about those? And the answers are changing pretty frequently. So there's two big companies now that offer blood tests to screen for cancer. So there's two big companies that are out there. Galleri, so Galleri is one, so you send out a blood sample, and they can test it for over 50 cancers. The cost is around $950. It is covered by some insurances, at least some of it. Can be used if your HSA or FSA you can use towards that. The benefit, you know, one is it's a blood test, so you don't have to deal with all that other stuff. But two is we can look for other things, and it's pretty specific. So if we're looking at cancers of the head and neck, it's 85% sensitive. So it's really effective for that. Pancreatic is another one that we very commonly find very late. You can identify that earlier. Ovarian, same thing. We don't routinely screen for ovarian, but we find it late. So, you know, the newer tests do have ways for us to look at a bunch of different cancers. But if we look at lung, we drop down to 75% effective. Breast, we're down to 30% effective. So it's not going to completely replace, but it can supplement, especially if we have concerns about what about those other ones that I don't have a screen for. The other one is CancerGuard. So that's made by the same manufacturers of Cologuard that I mentioned earlier. So that is to look, same thing, 50 cancers, starting their recommendations are usually age 50 to 90. Their cost is a little lower at $689. Galleri was first. They don't have any insurance coverage yet though, so I think that's why their cost is on the lower end. But for people who do have concerns about what if, then that might be something that could lead you to explore those. And as time goes on, I think we'll get more adept at using tools like this to assess a broader risk. Yes?
When would you recommend having those? Like, is it one of those cancers like runs in your family, or?
Yeah, I mean, a lot of times it can be if one of those, or if cancer runs in your family. Just cancer in general. Because there's a couple of different, what we call a two-hit hypothesis, right? Which means that genetically you're kind of predisposed, so that's the first hit. And then something happens, and that's the second hit. So maybe that's I'm genetically predisposed, and I smoked. And now I get that. But like I said, if you smoked, I mean, the list is immense for the cancers, you know, lung, stomach, mouth, throat, colon, bladder, kidney, prostate, leukemia, breast cancer, they're all higher if you smoke, even though they're not really directly in the path of it. So if you have those histories, but there are genetic conditions like MEN1, MEN2, where we see people who have cancers affecting a couple of different organs, pancreatic, thyroid. It just tends to happen together. So if you are concerned, then it's something. Right now, like I said, for the most part, we're looking from an age perspective, most of these are starting around 50. But if we do have earlier onset of cancer in the family, we can start earlier. It really just kind of depends. And right now, there's no clear guidelines like from those organizations saying you should do this. But it is something that's evolving, and it's something that for many people gives them some peace of mind. Especially, just yesterday my wife was saying, oh, they have this scan, you can get the whole scan top to bottom for like $4,000, isn't that cheap? I'm like, well, it's cheap. But it's not good, because we're gonna find stuff, and a lot of what we find is not gonna matter. So there is something that I did mention in medicine called an incidentaloma, which is a tumor that we incidentally find. That means absolutely nothing. It has no consequences whatsoever. It's just when you were growing and developing, your cells just took the wrong left turn and wound up growing a little more than usual and then stopped. But if you can imagine that happening 4 different places and the workup that will then follow for something that isn't clinically relevant. Versus these at least are looking at blood cells. So if these cells, like I said, you have cancer and it gets in the bloodstream, it can kind of spread distantly. This is helping us say, all right, we're looking at the bloodstream, can we identify markers of those cancerous cells? So this would be more specific than just a pan MRI, because a pan MRI is just showing you, hey, that grew more than usual. But it doesn't really give us a lot of additional information, and can wind up creating a lot more anxiety than it solves. So as those go forward, I think that'll change things somewhat, but I do think we're still going to have some of these that we continue to do. So breast is probably something that we're going to continue to screen for with some imaging, possibly also with the blood test, but because that sensitivity is lower, we may not do it as much. But it may become a mainstay for things we can't screen, like ovarian and pancreatic. So those are the ones that we kind of would usually look at. So family history of cancers of any kind, and personal history. Yes?
Hi. Both my sister and my mother died of pancreatic cancer, and the 2 stories that come out of that experience are, it's a death sentence, number 1, and number 2, there's no known cure. Those are the stories that came out of the experience. I have no idea whether it relates to science at all.
Well, it does. It speaks to that we don't have a way to screen for it. So we often find it when it affects things. So it metastasizes early, and so it's very hard to say that we got it because it usually has spread to many other organs by the time we find it. And it is resistant. You can be cured, but it's low. I think they have around a 5% survival rate at 5 years for stage 4. So once it's metastasized and it does that early, it can really be problematic. Melanoma does the same thing. For ovarian also tends to metastasize early, and so those tend to be really quickly dangerous cancers. With the pancreas, a lot of times the few that we do have great success with are the ones that have been close enough that they block off the duct. Right? Because like I said before, is if you see symptoms from what it compresses, so a lot of times it'll be painless jaundice, so they start to turn yellow.
Is there a cause?
Well, that is because it backs up, that duct backs up the gallbladder, and when we can't get rid of our bile, it winds up being soluble and goes into the bloodstream and it makes us get jaundice. We'll see the same with cirrhosis with people that are alcoholics, where the liver stops working correctly, that they can get jaundice as well. But a lot of times when people come in and say, yeah, I just started turning yellow, I don't know why, we're looking at that pancreas pretty quick.
with skin cancers, like melanoma these days?
So skin cancers are doing better. A lot of it has to do with screening. There's a lot more Mohs surgeons, and so we are looking at things more. There are, again, with AI, there's been some developments too. So there's actually some tools that you can take pictures of things, and it'll actually tell you how concerning it is from a cutaneous perspective. But we are still waiting to see it drop off. The reason being, when we look at risk for melanoma, the big concern we have is sunburns. When are we worried about those sunburns? Does anyone know?
Pretty young, pretty young, yeah.
Yeah, before 35. How many people under 35 are worried about their skin? And so at the point that you finally got kids worried about their skin, taking care of their skin, getting old enough that they're seeing it, so we haven't seen that drop probably yet with regards to, taking better care of our skin and using sunblock appropriately. But we are really looking closely at it. Part of it tends to be, again, if we are finding it, it's in hard to find places. Common question that I'll ask my patients, usually my male patients when they come in to see me, is do you have any, changing moles or lumps or bumps or anything your wife is worried about? Because they're going to see their back. We're not often able to really see what's back there. So back, a lot of times, and if you're out in the sun, that's where we can get a lot of sun exposure. And so I did have a gentleman who, we excised melanoma, wound up, he subsequently passed, but it was back of the neck where someone was like, wow, that looks weird, you should have that looked at. And so it's getting better, but it's still a work in progress. Yes?
Yeah, just a couple of comments. First of all, I just want to thank you for excellent discussion. All very interesting information. But just two quick comments. The other thing about the skin cancer is seeing a dermatologist once a year, particularly if you're over 50, 55, because, in primary care, remember, it's really hard to do a thorough skin exam. And
I had a biopsy this week.
yeah, and there's a lot of pre-skin cancers that the dermatologist will just freeze off and nail it before it becomes a cancer, and you get a very thorough melanoma screen. I was never great at dermatology; it wasn't my strongest. So I would say all of us just get the skin check, and then just with regard to what John had said about pancreatic cancer, I'm sure you've heard of this, John. There's been some studies that show if you have I can't remember if it's 2 or 3, first 3 relatives with pancreatic cancer, they have done studies where they subjected those people to an MRI of the pancreas, and they had a significant success rate at early detection of the pancreatic cancer. Because as you said, if it's early, you can be cured, but if you're stage 3, stage 4, it is 5%, 7%, 5 years time. So just wanted to mention that.
Great, well, thank you all.
Thank you.
Thank you so much, John, for being here. This was fabulous. Thank you all for being here. We will get more screenings and more. No, you won't hear about just a little.
Just a little.
Just a little. Just enough. Next week we'll be here again. We're going to be talking about the topic of scents, as in smelling, like scent, that kind of sense, and the Bible. So Christine Belinsky and I will be co-teaching a little conversation around that. So I hope you'll join us next week at 8:45 for that. But thank you, John, for being here, and we'll head on over to worship. What do you say, Nelson?
Break a leg, as they say in showbiz.
Remember, 2 or more.
3 minutes,
I'm like,
45
move it up right now.
seconds.
Get right now. You guys come. Yeah.
Claire just told me.
Yeah.